Hello, everyone. I'm Leonel August Rodriguez, the VP of Business Development for Access Medical Labs. I'd like to thank everyone for joining us on another Access Live, where we bring you insight from leading medical experts. We do ask that all questions be submitted via the Q&A, as they will be answered at the end of our lecture. Today, I am privileged to have an extraordinary speaker with us. He is truly a trailblazer in the field of traumatic brain injury and age management medicine. For over a decade, I've had the honor of calling this individual not just a colleague, but also a friend. His work has transformed the lives of countless patients and veterans, and his dedication to advancing integrative medicine has earned him recognition on global platforms, including the Joe Rogan Experience. He is a leader, he is an educator, and an innovator who continues to push the boundaries of personalized healthcare. It is my pleasure to introduce Dr. Mark L. Gordon.
Thank you, Leo. Thank you, Access. Thank you to everyone who has taken time out of the schedule to this lecture, which is, for me, probably one of the most important aspects in our age management medicine, anti-aging medicine, traumatic brain injury, psychiatric treatments. Because in the past almost 30 years, my focus has been on hormones and how they influence the neuropsyche of each individual, an area that's called neuroendocrinology. And for those who know the work that I've been doing for the past since 2009 with our military, we've been able to reverse their PTSD, TBI, symptomatology, depression, anxiety, bipolar, psychiatric conditions, just by correcting two key factors: the neurosteroids, the hormones that are produced in the brain, and the inflammation that is precipitated by any form of trauma, whether or not it is with loss of consciousness or not, subconcussive or concussive, doesn't matter. They all lead to changes in the chemistry of the brain. Prior to starting this presentation, Leo and I were chatting about one of the most important missed issues that just came about in 2018, the fact that the non-steroidal anti-inflammatory medications such as ibuprofen and naproxen have a deleterious effect on the Leydig cells of the testes and the thecal cells of the ovaries, and shutting down their ability to recognize luteinizing hormone. So a lot of the people that we've been seeing who have a history of being on these non-steroidal anti-inflammatory medications, that they have hormonal deficiencies, that we jump in without asking the questions and start them on hormone replacement without first analyzing or assessing why they develop the hormonal deficiency. So in this presentation, what we're going to do is go over some of the nuances that are relative to age trauma and neuroinflammation biomarker panel, interpreting the biomarkers, and learning about neurosteroids and their protection of the brain. So in 1995, when I started practicing purely anti-aging medicine, it was believed that the reason for hormonal deficiencies was due to genetics and aging. Well, in my world, that is no longer the case. Neurotrauma and neuroinflammation appear to be causes for hormonal dysregulation, and that is what we spent the last 3 years developing an understanding of the relationship between trauma hormones and neuropsychiatric illnesses, which you can read about at the website tbihelpnow.org under the science. So in my world, neuroinflammation precipitated by one of 1,000 causes is what we need to focus on. In a nutshell, these three statements: neurotrauma induces neuroinflammation, neuroinflammation alters neurochemical pathways leading to insufficiencies of neurosteroids, neurotransmitters, enzymes, cytokines, and regulation of body functions, and three, prolonged loss of healthy neurochemistry gives rise to neuropsychiatric and neurocognitive dysfunction, culminating in neurodegenerative illnesses such as Alzheimer's disease, Parkinson's, multiple sclerosis, and ALS. And for those of you who were in Utah last week with AMMG, I gave the presentation on Alzheimer's disease, a hormonal approach to understanding treatment. This is how we've reversed it. So neuroinflammation, regardless of how precipitated, has been found to be a major disruptor of production of hormones in the brain, the neurosteroids. And it appears that when you have inflammation, whether or not it was due to a vax and the inflammation caused by a vaccine, or a fracture of a leg, or problems with the stomach, or being hit on the head, or blast trauma, it turns out that this inflammation alters the functioning of a relationship between astrocytes and the hypothalamus, such that astrocytes are responsible for producing PGE2, prostaglandin E2, which helps stimulate the hypothalamus to release gonadotropic releasing hormone. So when you have inflammation, you lose the ability of the signal from the hypothalamus, the gonadotropic releasing hormone, to go to the pituitary and turn on FSH and LH. And that's one of the reasons why you lose the production of neurosteroids that start with cholesterol becoming pregnenolone, and then the whole steroidogenic cascade that happens. So the treatment, obviously, is to drop the inflammation. And we'll touch on some of that as we get through this presentation. Well, due to several processes initiated by trauma and aging, the cells in the brain called the microglia, which are the immune systems, they're responsible for dumping a lot of pro-inflammatory chemistry that leads to free radicals, that leads to shutting off this communication between the astrocytes and the hypothalamus and its inability to produce adequate amount of luteinizing hormone, which is the rate-limiting hormone that converts cholesterol to the start of pregnenolone, the mother of all hormones. Up in the left-hand corner, it says fractalkine. Fractalkine is only about 9 years old in our literature, and it is a hormone that is produced, or a chemokine produced by neurons, that tells the microglia to stay calm, cool, in what's called the M0 phase or phenotype, which is the sedentary surveillance mode. But when you lose fractalkine because of stress, cortisol goes up, fractalkine disappears, and the microglia start dumping inflammatory chemicals. This is how stress, if you believe in PTSD, how pure stress can lead to changes in the chemistry of the brain. Okay, so as I said, under stress, cortisol becomes elevated and shuts down a protective chemokine called fractalkine. Without fractalkine, microglias will transform from M0 to M1, the activated form of microglia. And that leads to damage to chemistry of the brain, the ability to make neurotransmitters, to make neurochemistry, enzyme systems, which are responsible for a lot of the problems we see. The elevation in free radicals creates a product called peroxynitrite. Peroxynitrite destroys some major enzymes, the ones that take L-tryptophan to serotonin, take L-tryptophan to melatonin. So you lose serotonin, increased depression, you lose melatonin, sleep deprivation syndrome. And it's just by the inflammation created by these microglia, along with any physical traumas. The effect of elevated inflammation is the disruption of both the hormones of the brain, neurosteroids, and those produced below the neck, the neuroactive steroids. Both have been found to regulate many, if not all, the functions ascribed to the brain. So we need to have control of inflammation both in the brain and below the neck. Looking at the disruption of the hypothalamic anterior pituitary axis and the production of neurosteroids, the loss of hypothalamic control over the pituitary can lead to diminished hormone production below the neck due to loss of pituitary trophic hormones that include TSH, LH, ACTH, and all the other stimulators for hormones below the neck. In cases of specific damage to an area of the hypothalamus called the periventricular nucleus, you can see dysregulation and loss of control of growth hormone and or prolactin, noted by them being elevated. Why is that? Well, prolactin is regulated by something in the hypothalamus called prolactin inhibiting factor. The other name for it is dopamine. So if you lose the production of dopamine, what will happen is prolactin will go up. When prolactin goes up, shuts off luteinizing hormone, therefore causing low hypogonadism. And how many of us are actually checking for prolactin? A very important add-on lab test, or a test that should be done. So it gives you primary understanding of primary hypogonadism, looking at the testicular dysfunction because of things we do to disrupt the Leydig cells, ibuprofen being one, excessive use of certain medications, chemotherapeutics, high temperatures. And two is luteinizing hormone in the pituitary from damage of the pituitary from trauma. And then tertiary is the inflammation affecting the release of gonadotropic releasing hormone. So we need to be able to look at each level. You know, primary hypogonadism, you look at what? LH, and you look at testosterone. In or you look at primary, you look at testosterone, free testosterone. In secondary, you look at LH, and the other, you look at the inflammation markers. So in looking at trauma and how it influences hormones in the brain, in this study that was done in 2006, it shows that within 3 months of having had a head trauma, you'll lose 56% of your production of hormones, broken up into gonadotropic, corticotropic, somatotropic, and thyrotropic. And then that's the acute phase. When we get into the chronic phase, which is in 12 months' time, what happens is you have an improvement by 20%. But if you look down at somatotropin, which is the growth hormone marker, you see that it continues to get worse. It turns out that the somatotropes, which are the growth hormone producing cells in the anterior aspect of the pituitary, that they're extremely sensitive to trauma and changes in blood flow. So after head trauma, what happens is that inflammation and that damage can continue to increase the production of deficiency of growth hormone. In the order of occurrence, you'll see growth hormone, gonadotropic, corticotropic, and then reverse that, thyrotropic, and then corticotropic. So you'll see that pattern occurring. So when we take care of adolescents that are in sports, what we do is we try to get a baseline laboratory test. And then if they have a head trauma, you don't get laboratory testing immediately. You wait for 3 months so you can see the changes. If you do it prematurely, you'll look at it and say, oh, looking at the baseline that you have and looking at the subsequent one, it's normal. Well, that's because you haven't waited enough time for that 3-month lag phase for the changes in the hormone levels to occur. For those of you who take care of any adolescents who are playing sports. So clinical signs and symptoms of hypopituitarism can be based upon these clinical symptoms and their associated hormonal deficiency: increased body fat, loss of libido, shortened lifespan. This is a Swedish study of 2005. Weight loss, attention deficit, memory loss, and diabetes, heart disease, and mood disorder. Vitamin D. Don't forget, vitamin D is a hormone and has come up to be extremely important across an entire spectrum of medical conditions, not only in the brain, but the heart, emotional state, with over 83,000 articles talking about vitamin D reducing depression, over 2,700,000 articles of vitamin D helping to protect the heart from heart disease, and almost 3 million articles about how vitamin D protects you from diabetes. And we'll talk about the ranges a little bit later. One of the problems I see in a lot of cases that come into us is that we're not treating people with therapeutic levels of all the hormones. For some reason, we've looked at growth hormone and testosterone as the ones to abuse, to use in very high dosing, and ignoring all the other ones. And we'll talk about that as we move forward. So the biomarker panel of TBI and aging, this is a list that took us 14 years to put together and test out over the past 30 years. And these laboratory tests can be used for any aspect of assessment of people. It doesn't have to be just TBI, anti-aging wellness, or age management. It's the entire gambit of it. And sometime next year, I'll be sharing with you the automated system that analyzes this. It's a AI software application, which will make this takes these 28 markers and analyzes it 28 to the 28th power, gives diagnoses, educational facts and directions, as well as predictive treatment. So in looking at the list, we're going to start with growth hormone, which peak production of GH is between 8 o'clock at night and 4 in the morning, where it does its thing, as well as turns on about 9 proteins in the liver. So in the morning, we should find growth hormone low or low normal. And when growth hormone is found elevated, it could represent a pituitary adenoma, damage to the periventricular nucleus of the hypothalamus, a medication effect, high estrogen in women, and or a supplementation with growth hormone. A lot of times I was asked, Doc, if you know it's going to be low in the morning, why do you test it? Well, it's to find those abnormalities. And in the population I work with, it's a very common occurrence in the professional sports world, as well as in our military population. So this first one is growth hormone is elevated, IGF-1 is low normal, and binding protein 3 is within the normal range. And this can be found in alcohol, medication, those people who use anastrozole, because anastrozole, the estradiol blocking agents or the conversion products that block estradiol synthetase, specifically for some reason influence the production of IGF-1 in the liver. So if you have people who are on clomiphene or enclomiphene, it can influence the production of IGF-1. I don't chase after it, I share it with the people. And another issue is fatty liver degeneration. That could be either alcoholic fatty liver degeneration or non-alcoholic. They both cause it. And then in a normal presentation, you see the low growth hormone level. I mean, I call it normal morning level. And IGF-1 is pretty good, and their binding protein 3 is normal. And then in this one, you see, which is adult growth hormone deficiency syndrome, when you see across the board, all 3 of these are low. Now, growth hormone goes to the liver and directly stimulates binding protein 3 production. There's a linear relationship between, I think I've got a slide on that someplace in here. But it's doing these 3 in the morning is important, especially on the initial assessment, because it gives you an understanding of what's going on. If you've got great amount of growth hormone, but low amount of IGF-1, think of these things. And we've picked up hepatomas. We've picked up mostly fatty liver degeneration, as well as certain medication like blood pressure medication, hypertension, and cardiovascular medication seems to influence it. Also, things like valproic acid with seizures, and high levels of free testosterone. And in this one, periventricular nucleus damage. When you damage the periventricular nucleus in the hypothalamus, you lose the somatostatin, which controls the production of growth hormone. So you can see very high levels of it. And that's trauma to the hypothalamus. And I see that in blast wave traumas. We've got guys that were IED, EOD, explosive ordnance and demolition, which their job was to deactivate the roadside bombs or blow them up. And a lot of times they get caught in their own blast waves. And that's very damaging to the frontal lobe, as well as to the hypothalamus. So one of the many benefits of growth hormone is the ability to modulate inflammation both centrally and peripherally. In cases of atypical depression with treatment resistance, they found in this study that 61% of the patients with adult onset growth hormone deficiency were found to have atypical depression. And they were given medication, didn't work. They were given tons of medications and it didn't work. This is what I see in our military. And when you fix the growth hormone level, which can take 1 to 2 months to fix it, they get better. And they also get 4 improvements. They sleep better, they have better cognitive abilities, brighter minds, their interpersonal communication skills are better, and they're less emotionally reactive. And we believe that's all due to controlling modulation of inflammation as well as return of the ability of the brain through L-tryptophan hydroxylase to make serotonin and L-tryptophan decarboxylase to go further to make the melatonin. So you actually recover enzyme systems that have been lost due to inflammation. So IGF-1 is made for the most part in the liver, about 75%. Therefore, poor production can be attributed to issues, as we talked about, due to alcohol consumption, drugs, prescription medication, fatty degeneration, both the alcoholic and non-alcoholic form of it. So, as I said earlier, clomiphene citrate seems to decrease IGF-1. I have a couple of people where it doesn't do anything. Interesting genetics. But as a given, anticipate that use of clomiphene and eclomiphene will lead to some reduction in IGF-1 level. You knowing that, you being able to share it with your clients will help to diminish any kind of stress relative to, oh, it's reduced. So the issues with free IGF-1 is it only lasts 8 to 10 minutes in the blood, but when it's bound to binding protein 3, it lasts for 20 to 24 hours. And just for clarification, when you do from Access Labs an IGF-1 level, it gives you both the bound and free forms. So the importance of IGF-1 in traumatic brain injury and in aging. You know, when I say traumatic brain, also aging is a very important component of it. Well, IGF-1 is a pleiotropic hormone like most of them are, meaning that they have a multitude of tiers of benefit. And it can be upregulated, and it can upregulate the ribosomal production of protein synthesis. So if you have people with poor healing and low growth hormone IGF-1 level, this might be the reason for it. And as you can see in this highlighted area, it increases directly neurotransmitters, receptors, protein for the cytoskeleton of cells, and it inhibits apoptosis in neurons. So it helps survival of neurons, neuroregeneration as well, and it stimulates dendritic growth, angiogenesis, and amyloid clearance. Amyloid clearance is the importance in Alzheimer's disease, as well as in CTE, as well as in Parkinson's. They all have some degree of amyloid development, beta amyloid specifically. So in 2008, they recognized that deficiencies of neurosteroids such as growth hormone and IGF-1 and also IGF-2 can cause failure of neurons to generate and regenerate, and not the premise that they are incapable of doing so has long been the opinion. What I mean is that we think that it's just the inability of the neurons to be able to regenerate and to repopulate themselves, but that's not the case. What the case is, the environment that the neurons are sitting in is not neuropermissive, and that's due to inflammation, change in the chemistry, and loss of neurosteroids, the hormones of the brain. Binding protein 3 is extremely important. It's produced at night under the guidance of growth hormone to the liver, and with its 20 to 24-hour half-life, it's very easy to pick up in the morning. For us, we use binding protein 3 as a marker for how well growth hormone was produced at night between 8 at night and 4 in the morning. So this is that graph I was referring to. This is IGF-1, this is growth hormone, and this is binding protein 3. So if it's produced peak at this time, and then in the morning you go and measure it here, you know it's the best reference for growth hormone, unless you want to go to the person's house at 12 midnight and draw their blood to get a peak level. I don't think so. So this is a good alternative, binding protein 3. So looking at the 6, and now there's a 7th binding protein, they're extremely important. Unfortunately, I have not been able to find a laboratory that measures anything other than binding protein 3. I'm trying to push Access to be the first one to be able to run these tests because of their importance. Binding protein 1 is cardiovascular protection, reduces risk for cardiovascular. Binding protein 2 is, besides an adaptogenesis, improves insulin sensitivity. So for those of you who do insulin as the first insulin, fasting blood sugar and hemoglobin A1C with every new patient, you might be picking up the fact that insulin is elevated. And what I mean is if they've fasted for 8 to 12 hours and you have a number greater than 10, normal is 3 to 10, if it's greater than 10, that's a flag that there is some issue going on with optimal, ideal control of insulin. Then you look at the glucose level, if it's normal or not. A lot of times people are not getting their insulin level done. And when we go back and get their insulin, we find that they have insulin resistance, which can be due to chromium deficiency, vitamin D deficiency, DHEA deficiency, and DHT deficiency. Why? Those all regulate the GLUC4 receptor, which allows for the transport of glucose from the serum into the cells. DHT and DHEA selectively appear to improve muscle cells and their GLUC4 receptors bringing sugar in. So that's how you get better muscle repair, growth, and recovery after exercise. Binding protein 3, we know it's the carrier, the key carrier of IGF-1, but it has incredible anti-cancer effects. In the Melbourne Collaborative Study from Melbourne, Australia, they found a 48% reduction in specific colon cancer death with ideal levels of binding protein 3. And then binding protein 4, anti-colon cancer, has apoptotic effect. In chemotherapeutics, in oncology, one of the greatest failures for cancer treatment is that the cancer learns how to bypass the effects of the chemotherapeutic agents. And what happens with binding protein 3 and 4, it more rapidly destroys the cancer as opposed to giving it time to figure things out. Binding protein 5 with bone, and then binding protein 6, it promotes neuroprotection and promotes neurogenesis. So we know by using growth hormone in people with any of these issues, you'll see improvement. If you look at growth hormone and cardiovascular disease, growth hormone and insulin sensitivity, it increases it. It also decreases the inflammation associated with Alzheimer's disease, which is being called the type 3 diabetes. Why type 3 diabetes? There's dysfunction of the GLUC4 receptors. And I just gave you information on how you can reverse that. Okay, so this is the cholesterol steroidogenesis chart. And this is exactly the same cascade that happens in the brain. So luteinizing hormone is the key. The same thing happens in the brain. Going on to pregnenolone, which is the mother of all hormones. As we know, it is the precursor to the pregnenolone, to progesterone, allopregnanolone, cortisol, aldosterone, and then on the other limb to DHEA, down to testosterone, estradiol, estrone, estriol, and so forth. And pregnenolone has some additional benefits in being anti-inflammatory, also stimulating GABA. And a lot of our military who have deficiency of pregnenolone, they can't sleep. You correct the pregnenolone level, bring it back up to the 75th percentile, 50 to 75th percentile of the laboratory range, and what you get is people starting to sleep. On the other side, it has anti-inflammatory effects, synaptogenic effects, and neuroregenerative effects. And when you look at studies on Alzheimer's disease, the frontal lobe, all the pregnenolones and the pregnenolones and progesterones in the frontal lobe are lost. That is attributing to why executive function issues occur, frontal lobe dementia. Also, it turns out that pregnenolone sulfate, the activated form in the brain, which is where most of it goes, has 100 times more potent in inhibiting presynaptic GABA synapses, which means that when you increase GABA, it quiets you down. So if you look at the studies relative to detoxing from benzodiazepines, pregnenolone works because the receptor on the GABA A cells, or GABA A receptors that are called the benzodiazepine receptors, are truly the pregnenolone receptors. So you can get benefits in agitation, aggression, edginess, and anxiety, panic attacks with replacing the pregnenolone, if you look for it. Progesterone substrate of 5-alpha reductase is used to become allopregnanolone, and that's really one of the key issues with progesterone, knowing what the progesterone is. Allopregnanolone, we do not have a convenient available laboratory testing. Hopefully Access will, come up and do that. It's extremely important. Allopregnanolone was invented into a new medication called Zulrosa about 7 years ago for $34,000 a year. That's just the medication. You have to go into the hospital for 30 hours every month to get an IV, slow drip of the product. So it's about $150,000 a year for using the medication. And it's being used right now for postpartum depression. It has wonderful effect on depression, anxiety, and also improvement of sleep. And that's all from pregnenolone to progesterone, progesterone to allopregnanolone. And in studies that we look at, the biokinetics and bioavailability of pregnenolone, fat-soluble hormone you take by mouth, gets absorbed rapidly, gets through the BBB into the brain, and gets converted to pregnenolone to progesterone to allopregnanolone. All the enzyme systems are there in the brain to have that happen. Pregnenolone, extremely neuroprotective, neuroregenerative, drops inflammation. Progesterone has been shown to reduce cerebral inflammation and inflammation as well as edema of the brain extremely well. And whether or not it's truly just progesterone, the fact that progesterone becomes allopregnanolone is being debated, but it's probably all three. So allopregnanolone elevations following pregnenolone administration. This is the verification and validation of it. And this is the Zulrosa that I was talking about. And that's how important allopregnanolone is. So for now, since we don't have allopregnanolone measurements, we use pregnenolone and progesterone as markers for whether or not there's adequate amount of precursors, substrate to be converted into allopregnanolone. One of the negative issues is the 5-alpha reductase inhibitors. The conversion of progesterone to allopregnanolone, just like the conversion of testosterone to DHT, is predicated on the availability of 5-alpha reductase. If you block that enzyme, you lose allopregnanolone. And that's why we have the post-finasteride syndrome foundation, which tries to correct the deficiencies created by 5-alpha reductase inhibition. It's been thought that it's, DHT. It's not. The key factor is the allopregnanolone deficiency. So DHEA, extremely important, has so many benefits throughout the body. DHEA, can go down estradiol and end up being estradiol. DHEA comes from the 17-hydroxypregnenolone and could go down to estrone. And if there is a block in the enzyme that allows DHEA to go to androstenediol to estradiol, what happens is estrone builds up. And Framingham study, cardiovascular study, published a paper showing that if your estrone level is higher than your estradiol level over the course of 8 blood tests, you have a 60 to 90% increase in developing type 2 diabetes. And, when it came out, 8-9 years ago, I added estrone to our testing. So looking at estrone and estradiol, which is called the E1, E2 flip. Additionally, DHEA in the Mayo, Massachusetts study, what they found is looking at quartiles. Quartiles are 0 to 25, first quartile, 25 to 50, 50 to 75, 75 to 100. What they looked at is DHEA, their quartiles, black being in ischemic heart disease, with black being death, gray being survived the heart attack. And this was a prospective study of 17,000 men, 40 to 70 years of age. And the lowest quartiles were associated with the greatest amount of cardiovascular events. Looking at the fourth quartile of DHEA, you see that there's no black. So this is a great reason why, when we're looking at a comprehensive hormonal testing of our patients, that if DHEA is lower than the 50th percentile, you want to bring it up towards the 75th percentile so they get within the fourth quartile, so they get the added protection. Again, DHEAS has some incredible benefits. Besides these, they increase growth hormone production 10% in males if you take the DHEA 15 to 30 minutes after dinner, not in the morning. If you take it in the morning, you lose the benefits of the growth hormone, added growth hormone production. In women, it's 15 to 20% increase when they take it at nighttime. DHEA, anti-depression, anti-interleukin-6. You get a cold, you feel irritable, you don't feel so good, you don't feel so smart. That's the interleukin-6. DHEA can help reduce it. DHEA specifically directly stimulates the oligodendrocytes to produce more myelin, helps with myelination and remyelinization, as well as you've got all the dopaminergic, glutaminergic, synaptic transmissions are improved. That's how important DHEA is. And when you use testosterone and do not supplement with DHEA or pregnenolone, you lose it. LH is shut off when you use testosterone or estradiol. So you mandatorily need to add DHEA and pregnenolone back into the mix when you're using any of the other hormones. So DHEA is an interesting case which was picked up from our work at Fort Bragg in North Carolina. And what it shows is that DHEA is high, but free testosterone is low. And yes, DHEA does convert to free testosterone. It's how we get it. But it's disproportionate. And what we found is that the guys at Fort Bragg were doing kill house. They were shooting a lot. And what was happening is they were exposed to lead and mercury, which blocks the ability of conversion of DHEA to free testosterone. So if you see this pattern, go get heavy metal toxicity testing. Okay, free testosterone is the key. Free testosterone is what runs everything. Total testosterone gives misdirection. Here's a case, true case, a veteran who saw the VA endocrinologist twice and was told, oh, you don't need testosterone. But look at his free testosterone level. It's very low. If you do the 2% rule, he should have 17, 8, 8, 16, 17 of free testosterone, but he doesn't. Where is it going? Well, it goes to all the other stuff, epitestosterone, all the junk that gets called total testosterone. So these are all the things that represent total testosterone, but it's the free testosterone that gets right into the brain to help then get converted to DHT. We need to stop looking at total testosterone as the the director of what we do. It's the free testosterone. So I can bypass this. This is the ibuprofen alters human testicular physiology to produce a state of compensatory hypogonadism. That compensatory hypogonadism to the general medical industry that's looking at testosterone levels, we'll call it primary hypogonadism. But now that you know that, if you ask the simple question, have you ever used ibuprofen? And there's no date on it. There's no timing. If they used it 10 years ago, 5 years ago, last week, whatever. If they've used it, it will shut down the ability of the Leydig receptors on the LH receptors on the Leydig cells to recognize luteinizing hormone. It's a transcriptional suppressor, is how it's been found. And the thing that scares me the most, especially having had 3 grandchildren recently, is the fact that if a mother takes ibuprofen or one of the non-steroidal anti-inflammatory, it goes into the baby's circulation and can shut down their hormonal production. Remember, at 7 to 8 weeks, you got the first spurt or a spike of hormones that help the XX or the XY identify as that gender. And then at 1 to 3 months postpartum, it happens again. I wrote a paper on my website, which is called Gender Dysphoria Due to Endocrine Disrupting Hormones, talks about this. So it's a very quick read. So free testosterone is low and luteinizing hormone is high. Everybody says, oh, this is primary hypogonadism. Have you ever used ibuprofen or naproxen? Yes, you did. How much did you use? Well, the military guys use 800 milligrams 2 to 3 times a day for cycles of weeks, months at a time throughout their entire career with the military. Importance of testosterone is it stimulates CD4 cells, lymphocytes, and also increases the most effective anti-inflammatory interleukin 10, which shuts down things like interleukin 2, 3, tumor necrosis factor alpha, interleukin 6, interleukin 1, and 1 beta. Cognitive functioning declines in men as we get older if their testosterone levels are low because of all the beneficial effects of the bioavailable testosterone in the brain, lowering inflammation and helping with the limbic system. DHT is key here, is the active form of testosterone. In the DHT format, it's stuck below the neck, so it can't go into the brain. It has to be made in the brain. That's why they talk about people who use DHT congeners like decadurabolin and some of the other DHT-like products, and why they get sexual dysfunction is because they don't get any DHT into the brain, testosterone, to convert to DHT. So you lose the ability to create a cascade of other hormones that regulate brain function and libido. Also post-finasteride from the Proscar, Propecia, now Avodart. Sex hormone binding globulin. Sex hormone binding globulin's been getting a bad rap. Everybody freaks out over it. It functions below the neck. In fact, sex hormone binding globulin can bind estrogen and testosterone, and once it binds it, it has its own receptor at the cell membrane. It's not just the testosterone estradiol that have their sex hormone receptors on the cell membrane to activate the signaling into the nucleus. It's also with the sex hormone binding globulin. My concern is that if you have too much sex hormone binding globulin, you don't have enough, possibly, free testosterone to get into the brain, which is the focus of everything that we do. You got to have adequate amount to get into the brain. Below the neck, it's not an issue. And let me back up a second. The reason for sex hormone binding globulin going up is 2 reasons. Well, 3. Sex hormone binding globulin is produced in the liver and is suppressed by free testosterone. Sex hormone binding globulin produced in the liver is stimulated by DHT. Sex hormone binding globulin is stimulated by estradiol. When you use topical testosterone, you produce a lot of DHT, which stimulates the sex hormone binding globulin. So if you have a patient who's using topical testosterone and they have elevation in sex hormone binding globulin that binds the free testosterone, stop the topical. Go to injectable, or better yet, go to enclomid or clomiphene citrate. Let's see, we can bypass that. This is basically just talking about in women that luteinizing hormone, as it goes up, is associated with increased occurrence of dementia and cognitive impairment. It's not the LH going up, it's the fact of what it represents, and it represents insufficiency of estrogen and androgens. So you see, our goal in treating women perimenopausal and menopausal is to make sure the luteinizing hormone and follicle stimulating hormone are below 10 if it's menopausal. Why? Because then we know we're getting adequate amount of free testosterone and estradiol in the brain to do all the beneficial effects that we need to have it happen. Blocking Alzheimer's, blocking dementia, maintaining cognition, maintaining libido, sleep, sense of well-being, just a whole litany of benefits. So our goal isn't to force high levels of free testosterone and estradiol That's not what we monitor. What we monitor is the effect on luteinizing hormone. And it can take 6 months to a year to bring it down to a normal range. Again, this is basically stating that hormones help with lowering the amount of Alzheimer's dementia in both males and females. Interesting aspect is this hydroxy group on estradiols is a free radical scavenger. So that's an added benefit. Estrone, talked about the E1, E2 flip, and treatment for that is with 7-keto DHEA. So if you see a high estrone and a low estradiol, we give them 7-keto. How long? 3 months. Then we stop. So this is the Framingham Heart Study. They found that a twofold increase in total of free estrone levels at examination was associated with 77 and 93% increase odds ratio of diabetes. Estrone is a more sensitive marker of diabetes risk than is estradiol. That's the E1, E2 flip. Estradiol, okay. Estradiol has some major functions on not only stimulating oligodendrocytic production of myelin, but also drops inflammatory signaling so you can reduce the production of interleukin 1, 2, 6, tumor necrosis factor alpha. So what am I saying? I'm really saying we need to make sure that we replace all the hormones in all our patients and bring it to healthy levels. For us, our healthy levels are between 25 and 35 years of age. So this is just an interesting study that came out of the COVID fiasco, where vitamin D, when it was elevated, had the least amount of mild cases of active COVID. Vitamin D and preventing it. There are 1,390,000 articles talking about vitamin D preventing COVID-19 infections, progression, severity. Severity is death. And in this bunch, there are also influenza A and B. It benefits those too. So the vitamin D, as I said in the beginning, incredible. You know, it helps stimulate cell, improves calcium influx, and cytotoxicity reduces, which can cause the apoptosis and injury to the cell. Besides bone health, I mean, everything that we're based upon, trained upon, is vitamin D in bone. Now we're getting a new education on all the other areas of medicine that has beneficial effects of vitamin D. Just go to Google Scholar and look up vitamin D and heart disease, vitamin D and cancer treatment, vitamin D and cancer prevention. Amazing stuff. Okay, the neuroendocrine. Between 2 and 15% of patients with TBI have low levels of free T4. Free T4, and that's because, again, in the hierarchy of how the inflammation interrupts the growth hormone, testosterone, estrogen, thyroid, and cortisol. It's very important to look at. And let's see. The interaction between growth hormone and thyroid, it turns out that growth hormone can increase the conversion of T4 to T3, such that it can give you an increased occurrence of reverse T3 unless your adequate amount of selenium, iron, B12, B6, B9, and low cortisol levels. So if you're using growth hormone and you start seeing changes in your thyroid, look for your reverse T3 and understand that you might not have reverse T3. You might just have this rapid conversion of T4 to T3. And what will happen is you'll get feedback on the TSH. So you'll have a pattern of elevated TSH, reduced T4, and higher levels of T3 when they're on growth hormone. Don't react. Understand what it is. Okay, that we can basically pass that. Okay. One of the most important markers that we use, this is what, 10 years, 11 years old, from Dr. Jostel out of Chicago. It's a mathematical model that helps us to relate TSH to T4 production. And the importance for me is the fact that when the mathematical math comes out at less than 1.3, it indicates that there was a central issue that occurred to cause disruption of the production of TSH-T4. And this we see a lot in our veterans who haven't disclosed or noted in their jacket that they've had head trauma. It could be because they never had a concussion, but they had subconcussive, repetitive gunfire, 50 caliber machine gun, breaching charges. They have 1.3, and I write a letter to the VA with the documentation showing that this indicates they had a head trauma. When the calculation is 4.1 or above, the problem's in the thyroid gland. And what you want to look at is reverse T3. If this is greater than 4.1, the reverse T3 is elevated and vitamin D is low. That pattern is associated with the possibility of Hashimoto's thyroiditis. We have a 70% concordance in our practice, or it could be Hashimoto's or Graves' disease. Okay. The importance of T3 is that it's made in the glia cells in the brain. And what it does is helps regulate the oligodendrocytic precursor stem cells. So it maintains these oligodendrocytic cells, the OPCs, as stem cells. When you lose T3, they mature to end stage producing myelin. So what's wrong with that? Well, if you have traumatic brain injury, you want to make sure that they have lots of these stem cells to provide the chemistry needed to help regenerate, recover from damage to neurons and glial cells. It's just the reverse T3. The whole thing is reverse T3 is the removal of which of the, there we are, which that's in the normal outer, and then in the abnormal reverse T3 takes the inner T3 out, or inner iodine out. That's the difference between the two. Doing the T3-R-T3 ratio gives you a number which, according to the literature, it should be greater than 1.06. In the past 20 years, we found that 2.0 and above gives a better outcome for our patient population. And I've got 5 minutes left. Understand that post-operatively, you can have a reduction in T3. You can actually have an increase in reverse T3, and this can cause problems post-operatively. Robin Williams probably had this problem because he was 13 hours in cardiovascular surgery, and days after that is when he committed suicide. So, you know, we lose a lot of hormones from surgical stress. You'll fix the problem, but it will create another one. So you have to monitor your patients. You might give them a little T3 preoperatively, you know, a couple of days before, and then afterwards to give them a little bit of T3 or Armour thyroid or AP or NP or whatever you have. Prolactin is really interesting, and we miss the point. Dopamine is what helps control prolactin. Dopamine, the prolactin inhibiting factor. When prolactin goes up, it causes thyroid releasing hormone and TSH to go up. So if you have elevated prolactin and don't know it because you don't check it, and you see an elevated TSH level and think, oh, this is someone with hypothyroidism, you'll start treating them for hypothyroidism while the real problem will be the prolactin. And how also you know that is because prolactin elevation shuts down luteinizing hormone, so you can't make the testosterone estrogen, as we talked about earlier. So additionally, dopamine, when you can't measure dopamine directly, so we use what's called a surrogate marker, and that's the prolactin. When prolactin's low, dopamine is usually high, and we see it in people on Wellbutrin, amantadine hydrochloride, using a natural product called mucunapurins, and certain other medications which have dopaminergic effects. Okay, ACTH and cortisol. When we exercise, we increase the production of cortisol directly through a secondary pathway, which is a non-traditional pathway. And therefore, if you would do ACTH and a cortisol level, you will see ACTH is normal and cortisol is elevated if they've exercised within 12, 24 hours of having blood work done. And you simply ask them, do you exercise regularly? Yes. When was the last time you exercised? Yes. What were the exercise you were doing? And if they were doing things like running a marathon, you then understand why their peripheral cortisol production will be increased. And what regulates that are some of the epinephrine, norepinephrine, and neuropeptides that are produced by the splanchnic nerve. And it's a splanchnic nerve that creates the issue. So ACTH is normal, and you've got an elevation in cortisol. Okay, so whether, you can read this, but whether it is part of a normal aging process or an accumulation of life's trauma, neurotrauma creates neuroinflammation. That neuroinflammation interrupts all the things we've already talked about and influences cognition and emotional functioning. And damage to the CPU, the brain, functionality leads to dysfunction, disease, and rapid aging. Caleb Finch from USC, one of my mentors there, wrote a book which basically talked about neuroendocrinology and how if you don't monitor it, that you'll see accelerated death because of the importance of all the neurosteroids in our brain to help maintain our mental functioning and reverse and stop neurodegenerative diseases that are so devastating. So also, it's the three-dimensional understanding of the laboratory results. Most of us were trained, we read it like an accountant, this line, that line, that line, but that's not the way it works. Everything is interactive, as I said about the prolactin and the thyroid, about growth hormone and thyroid, about growth hormone, prolactin, LH, and testosterone, estrogen. They're all interrelated. And that's what the importance of this AI laboratory interpreter is so important, because it does the work for you. It helps to review all that information, the MOA. And I think with that said and done, I raced through it, 11 o'clock.
Dr. Gordon, what can I say, sir? You never cease to amaze me. Perfect presentation. I mean, I have so many questions for you. I'll kick it off with the first one.
Sure.
So this one is in regards to neuroinflammation. If you could please elaborate on how aging itself acts as a form of neurotrauma and how this understanding impacts treatment strategies.
Great question. Absolutely great. What happens is, as we age, we forget something. We, based upon our age, the length of time that we've lived, have been exposed to traumas, subconcussive traumas. You can go to my website and read the article on subconcussive trauma, or it's a video someplace on, maybe it's on my YouTube. It talks about neuroinflammation and subconcussive trauma. So what happens is you're generating all these free radicals, and then it interrupts mitochondrial function. And what happens with mitochondria? When they're dysfunctional, they start generating more reactive oxygen species. And when you look at what fats generate 96 ATP, sugars 37 or whatever the number is. And then when you have trauma, only 2 ATP. So what does that mean? They have to work harder. So these free radicals are what creates things like peroxynitrite, a lot of the reactive nitrogen and reactive oxygen species that interrupt the neurochemistry of the brain. So what we need to do is to do everything as anti-inflammatory and stop the process. We've developed a couple of products that we use in our military. I just released the paper from our 2020 study in Camp Pendleton with the Marines. 65% of them were 50 to 100% better in 90 days on one of our products, because it works to drop the inflammation of aging. We've got, you can go and see the 95-year-old Korean War vet who had dementia, no longer has dementia after 6 months. His son, Special Forces, did the interview of his father and sent it to us. I had nothing to do with it, but it's other than supplying with treatment. So yes, aging, we forget about all the inflammatory processes, medication we've used, dysbiosis, gut, it's an area that is big time now, especially with my daughter, Allison, who does gut, brain, and gut. The cytokines go right into the brain and starts the process. So you have to look at the gut. You have to look at a history of injuries. You have to look at medication, antibiotics, car accidents, slip and falls, wave runners. I mean, on a couple of the Joe Rogans, we talked about just skiing, water skiing, where that bouncing is enough to create trauma in the brain. Anyway, you got it.
I got it. You know what? A shout out to Dr. Allison. She is as amazing as you are, sir.
Where do you think she learned it?
What's the
No,
saying?
she teaches me.
The apple
She's
doesn't
teaching
fall
me.
too far from the tree, yeah? No, she's
Pineapple.
amazing. And thank you for your work that you do with our soldiers and our veterans. It does mean a lot. Now, you touched on vitamin D a few times. How does vitamin D supplementation play a role in post-concussion recovery and broader neuroprotection strategies?
Great. Well, it turns out that if you look at the studies of vitamin D with autoimmune diseases, whether or not it's psoriatic arthritis, rheumatoid arthritis, Crohn's disease, they show that the vitamin D helps to modulate the inflammatory reactivity of our immune system. So by lowering the inflammation, it's less dumping of these inflammatory chemicals. So that's how it controls it. There's also effect on free radicals, helping to diminish reactive oxygen species, reactive nitrogen species. So vitamin D, I mean, if you go to Google Scholar and look up inflammation, pain, it reduces peroxynitrite. And I was at, where is it? Bethesda, Walter Reed gave a presentation on neuropathic pain. And neuropathic pain is where the inflammation in the brain causes minor peripheral traumas to feel like someone's cutting your hand off.
Wow.
And that's because it amplifies the signal, and that's peroxynitrate. So you go to Google Scholar, put peroxynitrate, and neuropathic pain, and you get all these articles showing the relationship. It's also responsible for insomnia.
Really?
Depression, anxiety. Peroxynitrite selectively damages an enzyme regenerating reductase called glutathione reductase in an area of the brain called the substantia nigra, which is responsible for where it's a density of dopaminergic neurons that release dopamine. So if you have inflammation and peroxynitrite, it'll damage the ability to protect those cells. So why do you think you develop Parkinson's? And in our veterans who have not had TBI, the occurrence of Parkinson's is 1 to 3%. In our veterans with TBI, it's 56 to 83% develop Parkinson's.
Wow.
It's in my presentation on Alzheimer's, because Alzheimer's, Parkinson's, they're all related. The chemistry is all related. It's just which one is more rapidly progressing.
That makes complete sense. And you touched on depression, right? So given the relationship between growth hormone deficiency and the potential of depression, what are key considerations that you would suggest for a physician or provider for safely introducing GH therapy to their patients?
Well, the way that we introduce GH therapy is we use secretagogue. We use an oral secretagogue, which has been on the market since 2001 in physicians' hands since 2006. By increasing your own natural production of growth hormone, you'll get a balanced balanced production of growth hormone, IGF-1, binding proteins, and so forth. But it's the modulation of the inflammatory chemistry in the brain. Again, it all goes back to inflammation and how that inflammation disrupts a multitude of biochemical, neurochemical pathways in the brain. And so what IGF-1 and growth hormone have been found to do is modulate, downregulate the inflammatory cytokines. And that's where you get the reduction in peroxynitrite, in hydroxyl groups, free radicals, superoxide, all these things start dropping.
Okay. Now, I want to shift focus a little bit. Let's talk about substances that can be addictive. So have you found any role in nicotine when it comes to PTSD and TBI?
I personally don't use it, though. They're stimulants. So if you have people that are neurostimulants, if you have people who have daytime fatigue, the question is, why do they have daytime fatigue? Well, the reason why they have daytime fatigue is because if they have peroxynitrite, it blocks the L-tryptophan decarboxylase, L-tryptophan hydroxylase, which gives you reduces serotonin, so you end up with depression, reduces melatonin, so you end up with fatigue, sleep deprivation, fatigue, depression. It's all grouped together. So if you remove the inflammatory peroxynitrite and its ability to be made, let me just tell you where peroxynitrite is made and some of the additional issues. Peroxynitrite is made from one molecule of reactive oxygen species connecting to one molecule of nitric oxide. Nitric oxide is important in the brain for vasodilation. Also, it's an intracellular signaling mechanism or molecule. So in the SPECT scans that are done, Dr. Daniel Amen being the one that does a lot of them, he sees these punched out areas. And those punched out areas represent areas where there's diminished blood flow. It's not damage. I mean, caused by a damage, yes, but the actual biomechanical mechanism is loss of nitric oxide because it's being stolen by the reactive oxygen. And to neutralize, maybe neutralize it, no, to make a worse product, peroxynitrite. And then, wow. Yeah, it's a convoluted, but it's so cool. I mean, the information.
Very much so.
So cool.
So I'll conclude with this question, okay? In the light of the link between neuroinflammation, TBI, and aging, what would you consider the most critical takeaways for optimizing quality of life in affected patients would be?
Yeah, well, go back to the beginning, correct the hormones, drop the inflammation. If you want to see people living a lot longer in time, and that's how Dr. Edward Reichbach, you can see his 3-minute video at 90 days on treatment and 180 at the YouTube site. I'll send you the link. And he is crystal clear. When I saw him at 90 days, you can tell there was still a little residual, but when you saw him on a television program being interviewed, his word acquisition, his sentence structure, his poise, his ease of communication, totally different. And then I did for his 95th birthday last month, we were on a 1-hour conference call with his son, and he was just crystal clear.
Sharp, huh?
Sharp.
Look at that.
He's not the only. He's not the only. We have others with cognitive impairment it's gone. Address the inflammation, you'll get better response on your hormones. It's the inflammation creating the hormonal deficiency.
Beautiful. And Dr. Gordon, before we wrap up, I know I said we have one last question, but this one snuck into the chat. So this is a two-parter. So what is the secretobe for GH on the market? And then are there any products that you use, helped develop that you would recommend for our audience?
Well, the dinotropin and secretropin was developed in 2001, and in 2006 was picked up by a pharmacy distribution company and has secretropin. And then we have dinotropin, which are secretagogues. I don't use the injectable ones because they work on one pathway and they can cause something called homologous deregulation, where it suppresses itself because you're only working with one receptor. Our product works with 5 receptors, and we've got thousands of doctors in 8 countries. We're licensed in Canada, we're in China, we're in Thailand, we're in Philippines, where else are we? Going to Australia and New Zealand now.
Amazing.
Yeah, the product works, inexpensive, and that's the secretagogue. The other question was relative to the products. The products we have, you can go to our tbihelpnow.org under the science and pick up the Brain Rescue data sheet, which breaks out every component of the 3 key products that we have, and the 3 key products and how they work. And then read the Marine study from 2020. It's about 12 pages. It rips apart their reaction, their response. It rips apart the composition of each of the products, and there's about 100 references on the product. Now, every product that we've developed over the past 16 years they've gone through anywhere between 8 to 16 years worth of clinical study. In our practice, yeah, we won't release anything unless it's been proven, and that's what the last study at Camp Pendleton in San Diego area was done. We've got a new product which is a medicinal mushroom, 6 medicinal mushrooms. Took 3 years to prepare the product, and then we're testing it right now on its ability to reduce inflammatory markers. And so it'll be ready for release probably end of this year, beginning of next year. Beautiful flavor. It's cocoa, so that you get the benefits of chocolate. The studies that have come out showing stimulation of bone marrow through cocoa. So we're using high-end cocoa in the blend, all made in the United States, all products from the United States.
The cocoa itself as well.
Cocoa is from South America, but the mushrooms are all grown here in the United States.
Oh, it's amazing.
Yeah.
Dr. Gordon,
not psychedelic. Not psychedelic.
That was going to be my follow-up question, so thank you for answering that for me.
Are you looking for psychedelics?
No, not at all. Not at all. Dr. Gordon, what can I say? Again, love you, love the work that you do, admire you for everything that you have accomplished, everything that you've done, and everything that you continue to do. You truly are an inspiration to us. So on behalf of, Access Medical Labs, I'd like to thank you again for another amazing webinar on the laboratory of TBI and age management. To our audience, thank you again for tuning into another Access Live, where we bring you insight from leading medical experts. Don't forget to like, subscribe, and stay healthy. Until next time.
Cheers.